The FDA, with the fact that there are now agents that were specifically tested in secondary progressive MS, went through the exercise of dividing the disease state of MS into CIS, the first event patients, relapsing remitting MS, active secondary progressive MS, and inactive secondary progressive MS. Obviously, separately to that is the primary progressive MS, that where patients have progression of the condition right from the very get-go. So at this point, most of the agents that we are having have an indication for relapsing remitting and CIS. They have an indication for secondary progressive MS that is active. The elusive agent is the ones that would be treating inactive secondary progressive disease. So at this point in time, there is no agent that actually has been formally approved. We all in the field believes that any agent that is currently used will be helpful in relapsing and secondary progressive disease, because most of the currently approved agents affect the immune system, affect the activity of the immune system. And so when I think about patients with secondary progressive MS, particularly patients with active secondary progressive MS, when I choose medications for these patients, I think of modes of action. And very important is that when I switch a patient or treat a patient with secondary progressive MS, is that the patient is on a new mode of action for this patient. What I mean by that, if a patient had had breakthrough disease on an agent class, then this agent class should be replaced by an agent of a new class, of a different class, in order to give this patient the opportunity to perhaps better respond to a different agent. Why is that? We understand that patients with multiple sclerosis may have benefits to a given agent versus another patient may be better responding to another agent. What I'm missing as a practitioner is the fact that I have no genetic test or biological markers that significantly guide me which agent I should use in a given patient. What has been shown as very important is that very early control of the disease gives the patient the best chance for long-term stability and gives the patient the best chance of not entering secondary progressive multiple sclerosis. So in a certain way, SPMS or transitioning into an SPMS, one could a little bit tongue-in-cheek call paying for the sins of the prior ineffective treatment in a patient. So ideally, in multiple sclerosis, we would try to control the patient at the earliest stages with effective treatment. If the patient has breakthrough disease on this early effective treatment, we would switch it with an agent of a different treatment class. And if the patient enters into secondary progressive MS, it then becomes very important to choose yet another class for this particular patient. Obviously, in secondary progressive MS, unfortunately, an element of progression may be inevitable for patients. So they may be progressing even if we control all evidence of appreciable inflammation. That's the reason why early effective treatment is important. Secondary progressive MS also raises other issues, and that's issues of what does the patient have in comorbid conditions. So it's not only what has the patient been on, because we don't want to repeat, it is also what does the patient bring to the table in terms of other conditions that may potentially affect the treatments that we are using. Agents for MS that may affect the heart, for example, or may affect the heart rhythm. In a patient with uncontrolled hypertension may be an issue. Patients with diabetes, certain agents may potentially be more favorable or less favorable. Patients with prior exposure to cancer medications, again, we need to think about that, because as we age, obviously, there is a higher likelihood that the patient has previously experienced such other conditions.